The topic for today's discussion is thoracic and thoracoabdominal aneurysm surgical treatment. The surgical repair of descending thoracic aorta and thoracoabdominal aneurysm remains one of the major challenges in the field of vascular surgery. Mainly because of the need for reimplanting brachiocephalic, visceral, and renal and other intercostal vessels, and also it has a very high mortality and high incidence of paraplegia post-surgery. So, as we know, the anatomical classification based on the Crawford classification. So the preoperative evaluation, as we saw in the last class, it will be in the cardiac evaluation, pulmonary evaluation, renal evaluation, and also the preoperative evaluation of spinal vessels also should be done preoperatively, which I'll be telling later. So once the decision for surgery has been made, the surgeon and the anesthetist must develop and execute the plan for repair. So the role of anesthetist is very important in TIA repair, and it is very complex, and it also requires multi-system monitoring and control. Arterial lines in upper and lower extremities should be inserted in the femoral and radial arteries. Central venous lines and a pulmonary artery catheter for monitoring central venous pressure and pulmonary artery pressure should also be made. And transesophageal echo to evaluate the ventricular function and valve function are used to optimize the mean arterial pressure and cardiac function. The EEG should be monitored to note the central nervous system activity in case patients who are put on deep hypothermic cardiac arrest. And the lumbar spinal drain is very important to monitor and control the spinal fluid pressure. Cell saver and adequate reservation of blood should be maintained. Endobronchial intubation should be done for the need for a single lung ventilation if needed. So the anesthesiologist's goal is to optimize the tissue oxygen delivery, intravascular volume, cardiac function, arterial perfusion pressure, maintaining MAP more than 90, in addition to keeping the spinal fluid pressure low without draining excess fluid. So the patient position patient will be in supine position in the lateral decubitus position with the left sided up. The shoulder should be almost at 90 degrees to the horizontal plane, and the pelvis should be tilted towards the left side for cannulating the femoral artery and vein in case needed for a cardiopulmonary bypass. And the steps of the surgery are incision, extracorporeal establishment of extracorporeal circulation, exposure of thoracic aorta, exposure of abdominal aorta and iliac vessels, proximal anastomosis, reimplantation of renal and visceral vessels, distal anastomosis, and finally the reimplanting the intercostal arteries. So the level of incision is determined by which portion of the aorta is to be replaced. In Crawford type 1 and type 2, where the proximal control is required just distal to the left subclavian, incision is made either at the 5th or 6th intercostal space. And in Crawford type 3 and 4, the incision is made either at the 8th or 9th intercostal space. So thoracotomy is made at the intended space, and the muscles serratus anterior, latissimus dorsi, and trapezius muscles are cut, and the thoracic cavity is entered. The left lung is deflated, and the aorta can be seen in the posterior aspect, just anterior to the vertebral bodies, and the control of aorta just above the aneurysmal part is to be taken. So the extent of exposure of the arch vessels depends on where the proximal aortic clamp is placed and requires avoidance of injury to the phrenic nerve and the vagus nerve and its recurrent branches, because injury to these nerves increases the risk for pulmonary complication. So since we are replacing the descending thoracic aorta, it has to be excluded from the circulation, which can be done either by passive bypass or an assisted circulation. Passive bypass is by use of a shunt, which is inserted just proximal and distal to the clamp site. It can be either in the arch of aorta or in the proximal descending thoracic aorta. This does not require any cardiopulmonary bypass machine. Just a God shunt is inserted proximal and distal to the aneurysmal part. In assisted circulation, there are many varieties. One such is a left heart bypass, where the inflow is taken from the oxygenated blood entering into the heart via either it is taken inflow from the left atrium or from the pulmonary veins, and it is connected to a centrifuge to the cardiopulmonary pump. And again, the blood is inserted. Through a cannula, it is inserted into the femoral artery for retrograde circulation, for retrograde perfusion of the visceral and renal vessels. The another one is the deep hypothermic cardiac arrest, where the use of profound systemic hypothermia to preserve organ function during cessation of circulation is termed deep hypothermic circulatory arrest. The hypothermic cardiac arrest requires complete cardiopulmonary bypass with arterial perfusion cannulas in the femoral artery or ascending aorta and venous return through a femoral vein cannula. So patients are cooled to 16 to 18 degrees Celsius, and then circulation is completely arrested. So at this temperature, the metabolic demands of the organs will be very low, and injury to the organs will be very less. So the exposure of the abdominal aorta, the diaphragm is incised through the aortic hiatus, which allows the complete exposure of the descending thoracic and abdominal aorta with its visceral branches and the iliac arteries if necessary. And left medial visceral rotation or the metox maneuver is performed, wherein first the left triangular ligament of the liver is incised, and then the left colon is dissected off the dissected via the in the line of told vascular plane, and it is rotated medially, and then the plane posterior to the renal kidneys is taken, and then the left renal is also rotated medially, and then the entire abdominal aorta can be visualized with the visceral and renal arteries. Similar picture showing the same. The left iliac artery is easily seen and exposed. The right may require dividing the inferior mesenteric artery at its origin to mobilize the distal aorta for better access to the right iliac artery. So once the exposure is complete, the systolic pressure is also maintained more than 100. Aorta is clamped, and the mean arterial pressure is always kept at greater than 100 millimeters mercury. In TIA patients, before or after opening the aneurysm, the ICA chosen for reimplanting or temporarily occluded using micro bulldog clamps, usually 2 to 4 arteries between T8 and L2. The remaining intercostal and lumbar vessels are quickly overswing to minimize blood loss and maximize collateral perfusion pressure. The Fogarty balloon catheters are used to occlude the visceral and renal arteries. At this point, the renal artery orifices are exposed, and each kidney is cooled with 300 to 400 ml of cold renal perfusion solution, which is 12.5 gram of mannitol and 1000 units of heparin per liter of lactated ringers. This gives hypothermic renal protection and further lowers the body temperature to 31 to 32 degrees Celsius to enhance spinal cord and organ ischemic tolerance. Similar picture showing the same. And then the proximal anastomosis is commenced. The proximal graft aortic anastomosis is performed using a 2-proline on a large CT1 needle. Depending on the tissue integrity, whether in case of dissection or calcium requiring aortic endarterectomy or just a fragile or thin aortic wall, a finer suture or finer needle is used, and or in a case of very thin aortic wall, felt strips or pledges may be used to reinforce the anastomosis. The next step is a visceral renal implantation, which is done by using the Carroll's patch. The Carroll's patch is kept as narrow as possible to avoid any patch aneurysms. If the vessels are spaced too far apart, they are attached individually to avoid a large visceral patch that is prone to aneurysm dilatation over time. The usual Carroll patch configuration is a celiac, SMA, and right renal in one patch, and the left renal artery attached separately. Another usually used configuration is celiac and SMA in one patch, and both renal arteries attached separately. This is a picture showing the same, wherein the Carroll's patch is nothing but the rim of aortic tissue, aneurysmal aortic tissue, just adjacent to the opening of the celiac, SMA, and the visceral arteries is taken, and it is reimplanted to the graft. Distal anastomosis is usually done at the iliac bifurcation, but if the iliac arteries are aneurysmal, the distal anastomosis is done at the iliac artery level. So only after finishing all this, the intercostal arteries should be reimplanted. It has been selected is done by biting the aortic graft, side biting the aortic graft, and reattaching the ICA using a button technique, similar to the Carroll's patch technique. And after the reimplanting the intercostal arteries, the patient is rewarmed, acidosis corrected, protamine is given, and hemostasis closure done. So the important aspect of spinal cord TIA repair is the spinal cord ischemia, which is the most dreadful complication. And coming to the anatomy of spinal blood flow, spinal cord is supplied by anterior spinal artery and a pair of posterior spinal arteries. Anterior spinal artery is a branch of the vertebral artery. It descends anterior to the spinal cord, and it is a very thin. Anterior spinal artery is a very thin caliber artery, and it has multiple reinforcing arteries from the at various levels. So in the cervical and thoracic level by the subclavian artery, superior via the superior intercostal, and the thoracic and lumbar aorta via the intercostal and segmental arteries, and branches of the interiliac artery at the sacral level. similar picture showing the same anterospinal artery being reinforced by the vertebral arteries, intercostal artery, and the branches of interiliac arteries. The extent of collateralization is not homogeneous across the whole length of the spinal cord. Even though there are 31 pairs of radicular arteries, the anterior radicular artery reinforcing the anterospinal artery is very less. The cervical anterospinal artery reinforcing the cervical radicular arteries reinforcing the ASA is only 0 to 6. The thoracic part it is 1 to 4, and lumbar part it is 1 to 2. And the most important is the artery of Adam Quicks, which is the largest anterior radicular artery that reinforces the ASA in the thoracic and lumbar part. It usually arises from the left side of the aorta between the T9 and T9 to L2 level. Sorry, T9 to L2 level. Sorry. The preoperative localization can be done via the MR angiogram. Herein where the picture shows the B is the segmental artery, and C is the anterior branch, and D is the posterior branch, and E is lateral anteroradicular artery passes upwards in the intervertebral foramen and takes a sharp U-turn and a sharp hairpin bend, and then revascularizes the ASA, which is shown in this picture. So intraoperatively also, there are two entities: the motor evoked potential and the somatosensory evoked potential. Motor evoked potentials column function, and somatosensory evoked potential detects the integrity of the lateral column. Intraoperatively, when clamping the renal, while clamping the intercostal arteries, the evoked potential is to be monitored, and at the segments where the evoked potential is becoming less, wherein the latency is more than 10 seconds and decrease in amplitude is more than 50% from the baseline, those spinal arteries should be reimplanted. At the anatomical part of the reimplantation, it is also found that on average half the intercostals are occluded from the disease process itself due to the degenerative aneurysm. The disease process leads to auto-collateralization that reduces the spinal cord ischemic risk associated with aortic replacement. There's also another aspect to the spinal cord blood flow, which is found out by the experimental and clinical studies that have demonstrated that spinal cord circulation during and after aortic occlusion aneurysm repairs via the collateral arteries, which is the coaxial collateral network concept. The more acutely obstructed ICA, intercostal artery, increases the decline in collateral network pressure, but it has been found that even without even without reattaching the ICA, the collateral networks will come to a baseline level 40% of pre-occlusion values within 24 hours and to 80% of pre-occlusion levels within 72 hours. So it's important to optimize this collateral circular perfusion network and spinal cord until the is done by perfusion pressure and neurochemical protection. So the neuroprotective strategies are one is to increase the tolerance to ischemia, which is done by intraoperative hypothermia, wherein the hypothermia reduces the metabolism and oxygen requirement in nervous tissue and prolongs ischemic tolerance and reduces cell swelling after transient ischemia and injury. And pharmacological neuroprotection it can be done either by intrathecal pepper injection or steroids, which stabilizes the neuronal cell membranes damaged during ischemia. Naloxone reduces the neurotransmitters that exacerbate injury. Barbiturates also can be given. It is done by deliberate hypertension, maintaining the MAP between 90 to 100, and also by draining the cerebrospinal fluid. Because in thoracic aorta, during thoracic aorta clamping, CSF pressure increases, and CSF pressure rises more than the venous pressure. It leads to closing of veins and reduction in blood supply. The blood perfusion pressure depends on the mean arterial pressure minus the lumbar CSF pressure. So the aim is to maintain higher mean arterial pressure and to reduce the lumbar CSF pressure. The lumbar catheter is inserted preoperatively in the L3 L4 subarachnoid space, and when the CSF pressure exceeds 10 millimeters mercury, CSF is drained. The pressure to be maintained is between 6 and 10 millimeters mercury, and it should be the rate of letting out the CSF should not be more than 15 ml per hour. The catheter is kept for 2 days post-operatively. And coming to the post-operative care, After open thoracic abdominal aorta repair, patients are in intensive for 2 to 4 days, depending on clinical progress. They are ventilated until adequate and able to breathe without assistance. After the patient can lift legs, SFP is monitored, but spinal fluid is not drained unless weakness develops. Cardiac function and hemodynamics are optimized with adequate volume replacement and inotropic support. The mean arterial pressure should be maintained more than 90 milliliters of mercury for the first 48 hours. To maximize collateral perfusion of the spinal cord, naloxone infusion is continued for 48 hours. Delayed paralysis can also occur after TIA surgery. It is by increasing the same methods by increasing the mean arterial pressure and mean arterial pressure, draining spinal fluid, and restarting neuroprotective medications. The most common complication following open repair is a pulmonary complication with a prolonged ventilation, pneumonia, respiratory failure occurring in up to 27% of patients. The loss of pulmonary muscle strength is associated with mortality in the elderly. The thoracotomy incision itself reduces lung function postoperatively. The higher the thoracotomy incision, the more risk of pulmonary complication. The higher the level of thoracotomy incision, the more difficult weaning from ventilator support will be. And the routine use of CPAP and adequate pain control may improve lung function and shorten the intubation after surgery. The effects of age and chronic disease on respiratory skeletal muscle strength may be the most important underlying factor in the survival and functional recovery of the patient. Come to renal complication, poor renal function is associated with more complications. Patients requiring post-operative dialysis are baseline renal mortality risk factors. Perfusing at high pressures with moderate or deep hypothermia decreases the chance of renal injury. Thank you, sir.